Welcome to Stratus. My name is Pam Wickett, and I'm the Labor and Delivery Coordinator for NRP. Today, I want to provide you with a review of each station and some do's and don'ts about how to handle the SIM baby. My hope is that you will use this information to help you review before you teach. A special thank you to my daughter Angela for filming. The first station we're going to review is PPV and chest compressions. Okay. I usually begin with an overview. I talk about the similarities and the differences between the flow inflating bag and the self-inflating bag. Then I move on to introduce the oximeter, the target preductal chart. Then I move on to PPV and Mr. Soper, and I end with chest compressions. So I'm going to start with the two different bags. The flow inflating bag and the self-inflating bag both can fit the same size masks. They both fill with room air or oxygen, whatever your blender is set at. Differences. The flow inflating bag, thus the name, needs flow to inflate. The self-inflating bag does not. It inflates by itself, thus the name, self-inflating. The flow inflating bag can be used in resuscitation because it provides 90 to 100% oxygen. Alone, the self-inflating bag cannot because it only provides 21% oxygen. You can, however, hook it up to a flow meter, and that will increase it to 40% oxygen, still insufficient for resuscitation. However, if you add an oxygen reservoir to your flow meter, you've now bumped the concentration up to 90 to 100, and it now can be used in a code. The flow inflating bag can be used to provide free flow oxygen. The self-inflating bag cannot. Nothing flows freely because there is a one-way valve. The only way anything flows is when you squeeze. However, if you disconnect your oxygen reservoir from the bottom and put it next to the baby's mouth, you now have free flow oxygen. Safety features. The flow inflating bag has a built-in manometer. The self-inflating bag does not. However, you can hook it up to one of these ports on the side. I believe it's right here. However, the self-inflating bag does have a safety device built in. It's called a pop-off valve, and it pops off when the pressure, or your PIP, goes between 30 and 40 centimeters of water. And this, as you know, is to prevent a pneumothorax. So ask yourself, why do we do so much teaching about the self-inflating bag? Because it doesn't seem as efficient. And the reason is twofold. Number one, if the hospital ever loses its gases, 21% room air is much better than nothing. And the other reason is transportation from the postpartum room to the nursery. The mother calls and says her baby's blue. We need some sort of oxygen to get through the hallways to the nursery. And I generally ask, does anyone have any questions? So then I introduce the oximeter. The oximeter is now the standard. We no longer assess heart rate, respirations, and color. We assess heart rate, respirations, and oximetry. And the reason it's the standard is for two reasons. Number one, there was a study done in Sweden that links too much oxygen at birth to childhood leukemia. And the other reason is it can take babies up to a full 10 minutes to go from their 60% concentration in utero to their goal of 85 to 95% concentration after birth. What are some of the indications that we would use an oximeter? There are 5. When resuscitation is anticipated, when PPV is required for more than a few breaths. I'm going to stop there for a minute. Generally, if you have a healthy baby that just needs a couple of puffs, they will bounce back. The babies who are not healthy will need more than a few breaths. Third, if you have central cyanosis, when you have central cyanosis, there's that mottled white look on the baby. That's very different from acrocyanosis, which is cyanosis of the hands and feet, which is normal. The other reason you might put an oximeter on is maybe your baby needs some supplemental oxygen. And finally, just to confirm your perception of, you know what, this baby doesn't look well to me. I think it's a little cyanotic. So now we're going to talk about how to set it up. The first thing you want to do is you want to turn on the monitor. It's this green button right here. And that's important to do as your first step because it has to calibrate. The button right below it is yellow. That is your silence button. In labor and delivery, this green on button is located in the lower left-hand corner, and the silence button is in the upper right-hand corner. And I do like to tell nurses where that is because these things tend to beep a lot and stress out both the nurse and the patients. Okay, so now you've turned it on. Now you have the O2 sat monitor. This can cause stress for a lot of people because there's a lot of steps. It's not hard though. So if you can come up with some mnemonic devices to help people, it goes smoother. For example, the right hand is always the right side. Okay, right is right. It is also because it's preductal, and preductal has the same oxygen concentration as in the tissues. You want to place it on either the baby's hand or the wrist because the capillaries are close to the skin and it's easy for the monitor to pick it up. Then, when you take the probe out of the package, there's usually a piece of paper. You peel it off. This is already peeled off. And you want to put it over the radial pulse. And how do you find the radial pulse? You take the baby's thumb, you follow it all the way down, and there's your radial pulse. Why do you want to put it on the radial pulse? Because your O2 sat monitor gives you two readings, the oxygen concentration and your pulse. So it makes sense that you would put your probe over the pulse. Then the next question, do you put the probe star to the sky or do you put the rectangle over the pulse? I spoke with the NICU and it really doesn't matter. The point is that if you put the first part of it at 12 o'clock, the other has to be directly below it at 6 o'clock, or as we call it, a radial sandwich. I will put it star to the sky because that's how we initially learned it. Then there is the Velcro, and the acronym for that is Blue Baby. Okay? Well, the mnemonic for that is a blue baby. You stick the Velcro, and the final step is you take the gold part of the probe and hook it up to the gold part of the oximeter cable. Keeping in mind that this probe is sensitive to the light from the life island, so if you have a little piece of blanket that the baby's lying under, if you could just cover that. The final step is to confirm that it's working properly. And one good way to confirm is to check the heart rate on the oximeter and match it to the heart rate of the baby. If they are the same, you have it is placed properly. I'm going to turn this off because it's going to start beeping. Okay, the next step we're going to talk about is the target preductal chart. A lot of people, come on over here, Angel. A lot of people get nervous when they have to explain this target preductal chart, but I'm going to teach you some tricks to make it less stressful. First of all, you can see on the left-hand side the numbers 1 to 10. Why is that important? Well, how many minutes does it take for a baby to transition from life inside the uterus to life outside the uterus? Up to a full 10 minutes. Now you're going to look at the actual O2 sat values on this side. Well, the first value starts at 60. Isn't that the same value that the baby was in the uterus? Or 1 minute equals 60 seconds. And it ends with our target goal of 85 to 95%. Okay, well that makes sense. How do you get from 60 to 85? Just add 5. 60, 65, 70, 75, 80, 85. And that usually helps people. People really like that. Oh, that's great, that's helpful. Okay, so now you have this O2 sat on. If the baby is in its target range, don't do anything. No supplemental oxygen is needed. Restrain yourself. If the baby is not in its target range, then you want to give free flow oxygen. Now, one of the things I learned from the NICU is that when you give free flow oxygen, you really want to start at your blender at 30. Because let's assume this is a term baby, your blender's set at 21. When you give free flow oxygen, it doesn't really go directly to the baby. A lot of it kind of goes into the air, and you're not really sure how much the baby gets. So they suggest we increase our blender to 30. And then we look at the monitor and see if the O2 sat goes up. If not, we increase it a little bit more, maybe to 35. If that still doesn't work, 40. Meanwhile, we have called the NICU, because whenever a baby's heart rate is not in the target range, that's a flag for us. And we can continue to keep turning it up. However, if the heart rate gets less than 100, we know that we now have to consider PPV. Another point of interest, if all of a sudden this beautifully working oximeter stops working, you have to pay attention to that, because you have to figure out if it's a mechanical problem, like the probe fell off, or if it truly is the baby does not have enough oxygen to perfuse its blood. So low that even the oximeter can't pick up. If you determine that it's the latter, that we have an oxygen perfusion problem, you must turn your blender all the way up to 100%. Okay. And then I ask, are there any questions? And we move forward. So now I go into positive pressure ventilation. So, just going to hook up a few things. So, the indications for positive pressure ventilation are the following: apneic or gasping, heart rate less than 100 even if the baby is trying to breathe, and persistent central cyanosis and a decreasing O2 sat despite 100% free flow oxygen. If you determine that the baby needs PPV, there's 3 things that you have to prepare. Number 1 is the flow meter. The flow meter, according to the book, can be set on 5 to 15 liters. We usually use 10 in labor and delivery. Your blender, if you have a term baby, term defined as greater than or equal to 32 weeks, that needs to be at 21%. Or if you have a preterm baby, it should be set at 40 or less than 32 weeks. And the final piece of information is when you bag the baby on your manometer, you want to use the pressure, begin at the pressure of 20 centimeters of water. Okay. So I'm going to turn this off. It's making a lot of noise. I'm actually going to use the self-inflating bag. So when you bag a baby, okay, I'm going to put them in sniffing position, which just means the baby's nose is pointed to the sky. And what I'm looking for is a nice rise and fall of the baby's chest, which you can see right here. Okay. Once you see a rise and fall of the baby's chest, your rate should be 40 to 60 breaths per minute in kind of like a waltz rhythm. Breathe 2, 3, breathe 2, 3, breathe 2, 3. Once you see a rise and fall of the chest, that's when you start counting your 30 seconds. You don't want to start counting your 30 seconds of PPV as you're still trying to get a rise and fall of the chest. If you're having trouble getting a rise and fall of the chest, then you want to move into your corrective steps or your Mr. Soper. So the first step in the corrective step would be adjust your mask, and by that probably just push it a little bit closer to the face and reposition the head. Try to ventilate, and you can see now we have a nice rise and fall of the chest. But let's say we didn't. The next step would be the S and the O. Actually, let me turn it this way so you can see. So for a term baby, you turn their heads to the side and you suction into their cheeks. Both sides. Then you open their mouth slightly in case they have an upper airway obstruction, and try to bag. So as you can see what I'm doing, I'm taking chunks of 2. The M and the R, I tried to ventilate. If that didn't work, I did the S and the O, I tried to ventilate. If that didn't work, then I'm going to move to increasing my pressure. So remember the pressure that we started with was 20 centimeters of water. I'm going to increase that on my manometer to 25. Try a couple of times. If that doesn't work, I'm going to increase it to 30. So forth and so on up to 40. Maximum of 40. If we go beyond 40, the baby can get a pneumo. If that doesn't work, we move on to an alternate airway. An alternate airway being intubation or LMA. And generally, LMA stands for, oh my goodness, laryngeal mask airway. And use those generally when you can't ventilate or intubate. The final step is chest compressions. The indication for chest compressions, if after 30 seconds of effective positive pressure ventilation, the heart rate remains less than 60. The major thing that you have to remember here is if you're doing chest compressions, these babies truly have an oxygen deficiency. Turn that blender all the way up to 100. We're not concerned about how little oxygen a baby's getting. We really want to give it enough. So now we're going to talk about the technique. There are two techniques. One is preferred. Let me just move this out of the way. So, the two-thumb technique is the preferred, where you interlock your fingers under the baby's back, put your hands around the torso, and have your thumbs meet at the lower third of the sternum. The second technique is the two-finger technique. You put your hands under the back for back support. Take your index finger, draw a line from nipple to nipple, and have fingers 3 and 4 fall into place. Now, the other thing we want to talk about is exactly how deep do we go when we press. So, by definition, we go 1/3 the anterior posterior diameter. So you are going down a good amount, much more than people think. And the final step here is that now that we have to add in chest compressions, we no longer can fit in 40 to 60 breaths per minute. These 40 to 60 breaths per minute bumps down to 30 breaths per minute in order to fit in the 90 compressions. So it looks like this with a new rhythm. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. And we do this for 45 to 60 seconds. And then we recheck the pulse. Obviously, we've called for backup. If the pulse is greater than 60, but below 100, we stop chest compressions and we continue PPV. But now we bump it back up to 40 to 60 breaths per minute because we don't have to fit in chest compressions. After another 30 seconds of positive pressure ventilation, we evaluate the heart rate. If the heart rate's above 100 and the baby is spontaneously breathing and your O2 sat is increasing, then you can stop PPV. Of note, you never just want to abruptly stop anything. If you stop PPV, you want to kind of transition the baby with a little free flow oxygen. Make sure it's still in its target preductal rate and make sure the baby's looking nice and pink. Finally, the baby will go to the NICU for post-resuscitation care. The flip side of that is once you check a heart rate after 45 to 60 seconds of both chest compressions and PPV, if the heart rate's less than 60, we know that we go on to epi. First dose would be through the ET tube, so the baby will need to be intubated. Meanwhile, someone is starting a UV line. And that concludes our station of PPV and chest compressions. The next station is intubation. Okay, so it's very important to select the right equipment. The first thing we want to select is the correct tube size. And as you know, we have 3 size tubes. We have a 2.5, a 3.0, and a 3.5. Okay. Now, a 2.5 is good for a 24 to 28 weeker. A 3.0, 28 to 32 weeker. A 3.5, 32 to 36 weeker. And because we don't have 4.0s, it's also going to be for a 36 weeker up to a 40 weeker. A good rule of thumb, a good trick that I learned, is if you take the size of the tube, like a 2.5, and multiply it by 10, that's 25. This is good for a 25-week baby. 3.0 times 10, this is good for a 30-week baby. 3.5 times 10, this is good for a 35-week or term baby. The ET tube also has some really helpful landmarks. You can see this blue radiopaque line right here. When you put it in the baby, it should be at the level of the upper lip. So the blue radiopaque line should hit the baby's upper lip. And that is helpful to show you good placement. The other thing that this has, if you look at the bottom, it has a slanted or beveled edge. And that side ventilates the left side of the lungs. And I remember that bevel has an L in it, L for left. The other side has a little circle. We call that the Murphy's eye. And the Murphy's eye ventilates the right side of the lung. And finally, we have a thick black line here. And that is the vocal cord guide. And that should be aligned at the level of the cords when we intubate. The next equipment that we're going to look at is the laryngoscope. Now before we begin, two things we want to check. We want to make sure the light source works and that we have the correct blade size. So the light source, what you would do is you take the blade off and just press. And if you see a light, you know you have a light source. If your light is not working, unscrew the bottom, and it's a AA battery. And FYI, if we end up using these in labor and delivery, they go in the placenta room in the yellow bucket on the east side. Now it's time to select the blades. The 00 is the smallest, and those are for the extremely low birth weight babies, or less than 29 weeks. The 0 blade is for preterms, and the 1 blade is used for term babies. So now we're going to work on inserting an ET tube. I like to put a stylet in first to help guide the tube. And I'm going to say I have a term baby, so I'm going to pick a 1 blade. And I'm going to hold the laryngoscope in my left hand. This is how I remember. Makes an L. So hopefully we get this in. If not, oh well. I'm going to just grab one of these. So what you want to do is you want to put the laryngoscope in and lift. And you want to see if you can locate the glottis and the cords, which I just had. All right, let's see. Okay. Using the stylet. Okay. Take the stylet out. And pray to God you're in. There you go. Yay! Okay. So then you want a bag, and we're checking for equal breath sounds. So how do we do that? We get our stethoscope, and the best place to check is under the baby's arms. Both sides. Okay. So if you have equal breath sounds, you know that your ET tube is in the right place, which is in the trachea. If you have breath sounds but are stronger on the right, you know that they're in the right main stem bronchi and it needs to come back just a little bit. If you hear nothing across the chest but you hear breath sounds over the sounds over the abdomen, you know that you're in your esophagus and this needs to be pulled. Once you've intubated the baby, before you check for equal breath sounds, if you're going to suction out meconium, put your meconium aspirator on, hook it up to suction at a value of 80 to 100 millimeters of mercury, and then you close the port and pull back gently, suction over a total of 3 to 5 seconds. And then you pull the ET tube out. If this is not from meconium and you need to ventilate, you put the bag over, put the bag on, and you can see the equal breath sounds. Okay. So that concludes our intubation station. The next station is the LMA station, and I'm also going to cover CO2 monitors. So there's two types of CO2 monitors. There's the color changing monitor, which looks just like this. And it goes onto the ET tube, blue side to blue side. And these are used for routine intubations. If they change color, you know that you have confirmation of placement. The second type of CO2 monitor is called a side stream filter line. And you take this end of the side stream filter line and you hook it into the ET tube, just like this. Put your bag over and bag. This filter line is used more for high-risk babies, particularly those who are on ventilators or are bagged for a long period of time. And the reason why we use them for high-risk babies is because they provide a little bit more information. For example, they provide capnography, which basically, if this machine was on, would be like wavelengths or waveforms. And that basically measures the movement of CO2 exhaled in each breath. It also gives us the CO2 value. It also tells us the respiratory rate. Okay. Should you have one of these CO2 monitors on, particularly the color changing one, you cannot put anything wet down the ET tube. So if you put surfactant down or you put epi down, this no longer works. A second little thing is, if you do put epi down the ET tube, generally only one dose works. Subsequent doses aren't that effective. So if you are putting something down the ET tube, someone is starting a UV line. And the last little tidbit here is that when you put the ET tube in and you're wondering exactly how far it should go in, a good rule of thumb is you take the baby's weight in kilograms and add 6. It's called the tip to lip measurement. So if your baby's 3 kilos, add 6, this ET tube should go in to 9. Okay. Now, let's talk about LMA. Okay. The LMA is an emergency temporary airway, and it's generally used for babies that you can't intubate or ventilate because they generally have some sort of upper airway obstruction. For example, Pierre-Robin syndrome, which is a small jaw, so the tongue gets pushed back and covers the airway, or bilateral choanal atresia, where you have blocked nares. There are 2 limitations for the LMA airway. You can't use them to suction out meconium, and you really can't use them for preemies because they only come in one size, which is a term. So let's talk about how to insert them for the placement. This is the LMA airway. First thing you want to do is you want to check the cuff and make sure that it is inflated and it has no leaks. You usually put in about 4 cc's. And I see that this cuff looks like it's had better days. Let's try again. Yeah, this cuff's not working great. Let me come over here. I'm going to try another 4 cc's. There we go. So then you want to deflate it. Then you want to take your finger like a pencil, just like this. You want to hold back the tongue, and you want to insert using the upper palate as a guide, and you will insert until you feel resistance. Then you want to inflate this with 4 milliliters of air. And then you want to check placement. And we are good. Okay. You should see equal breath sounds. well, feel equal breath sounds, you should see increasing heart rate as well as an increasing O2 sat. Excellent. All right, and then you would tape it in. And that concludes our laryngeal mask airway. So the next station is the code card. Generally, the NICU will do this, but for our purposes, what we really need to know are the contents in the first drawer and the third drawer. So in the first drawer, what's important to know? It's important to know where your epi is. It's important to know where your ID bands are, and there are two types. There's the Velcro kind. Okay, these are for these cases that come flying into the OR and right up into the NICU, and we didn't have time to get bands, and you just pin in the name. And then the other type of labels we have are the 4-band labels like we have in labor and delivery. Also important in this drawer are the green connectors. Some people call them the fluid dispensing connectors, and this is used when dealing with epi. So, these are all taped. All right, so you hook up your epi, pop the yellow off. Give us a little off. Okay. I think this might be empty. How interesting. Okay, so what you would do is you would take the green connector, screw it on, and then you would take your 1cc syringe or your 3cc syringe, depending if you're doing the UV line or the ET tube, push and pull. Okay? And these green connectors replace the 3-way stopcocks that we used to use. Okay, so let me just disconnect this, put this all back. Just discard. And the final thing of importance in this drawer are labels. Of course, they're blank here, but there are labels here. And the third drawer, this is your UV line. There's two types of sizes. There's the 5 French. Okay, they're all 5 French. There should be 2 different types of, anyway, oh yeah, and the 3.5. The 3.5 and the 5 French. And the NICU will let you know which type they need. Just put these all back neatly. And remember, we're going to go over this in the UV station, but you need a 3-way stopcock, which is right here, okay? And you need a flush. Where are my flushes? Here we go, on the top drawer. Okay, the flush for the UV line is in the top drawer, normal saline. And that's really all you have to know about the code cart. I wanted to spend a few minutes talking about the SIM baby, some of its restrictions, and what's okay to do with it. Okay. Let's first go over the restrictions. It is not okay to lift it, because if you look over here, it's connected to several wires that can be pulled. It's not okay to needle it, say if you wanted to get rid of a pneumothorax. It is not okay to put anything down the ET tube in terms of fluids. Somebody in the control tower making us breathe. Okay. What is okay is to trim the umbilical cord and to put something down it. Okay? So as you can see, the baby's breathing. The final point is that if you want to check breath sounds are heard best under the arms on either side. And if you want to assess a pneumo, you want to look at the bases. And that concludes our hints of the SIM baby. So this station is extremely low birth weight babies, plus the neopuff. So for those of us who work on labor and delivery, if anyone ever asks you to find the neopuff, we have 2 places. The first is right outside Rose's office, and the second is in the OR hallway. Okay. So extremely low birth weight babies are defined as babies less than 29 weeks. It is very important to keep these babies warm. So for example, if you're planning to go to the OR should be set at 72 degrees. You want to heat the life island all the way up to 100%. And you want to have these steri drapes available to place the baby after it's born. Once the baby's born, you want to remember two things. Number one, the baby always should be held flat. You never want to put the baby in Trendelenburg because the baby gets an extra flow of blood to their head, to their already fragile capillaries and vessels, causing them to potentially leak and give the babies a brain bleed. So always flat. And the other important point is you never want to dry these babies. So as soon as they come out of the uterus, they should be put right in the steri drape. And you want to cover them as best as you can because the steri drape keeps moisture in as well as prevents heat loss through evaporation. So Deirdre has told me to actually put a baby's hat on right over the steri drape, which I think is a great idea. And you want to wrap as much of the baby as you can in this. Some providers like to keep the chest open so they can see the rise and fall of the chest to make sure they're giving effective respirations. They also like to keep the cord visible for a possible UV line placement. You might also see a provider putting a hole in the side of the bag so the baby's right hand can come through in case they want to put an O2 sat on the baby. Okay. If you need to suction these babies, we do not suction them like term babies, where we return a term baby to the side and suction in their cheek. These babies, if you turn a baby to a side, you can actually cut off blood flow through their carotid arteries. So if you need to suction, you're going to take the entire baby and turn it to the side as a unit and suction. And then turn it back. Okay. Then the doctor may want to apply an O2 sat probe, and we apply it the exact same way as we do for a term baby. And the target preductal ranges are exactly the same as for a term baby. Risks: infection and hypovolemia. If PPV is needed for these babies while the NICU is on their way with the Neopuff, you can bag these babies just like normal, except your blender will be on 40% as opposed to 21%. Okay, so let's talk about the Neopuff. So the Neopuff. Neopuff needs an oxygen source flow meter, usually set on 5 to 10. I like 10. The blender should be set at 40%. Okay. The Neopuff is also called a T-piece resuscitator. As you can see, it kind of makes a T on the end. All right. So I'm going to turn this off so you can hear me, and then I'll turn it on when we need to use it again. There are two values that you need to set. This first circle is the circuit pressure. You cannot touch that. It's merely like the odometer in your car. The first value is your PIP, peak inspiratory pressure, which is the pressure given to a baby with each breath, the pressure given in the lungs for each breath. The second value we're going to set is the PEEP, positive end expiratory pressure. Let's start with the PIP. A good little teaching tool is, let's differentiate between PPV and PIP. PPV is just the act of squeezing the bag, positive pressure ventilation. The PIP, peak inspiratory pressure, is the actual amount of pressure delivered with each breath, or the value on your manometer. So if you give 20 centimeters of water, your PIP is 20. If you give 30, your PIP is 30. Okay. So, does it not make sense if our normal PIP or pressure that we give a baby is set at 20, that we would set up our PIP here also at 20? So how do we do that? I'm just going to put a mask on the end. I'm going to turn my oxygen on at 10. I'm going to place this mask on a firm surface, and I'm going to cover the top. Okay. And I'm going to set this, it looks like somebody already set it on 20. But if I were to set it, I'd be turning this value right here. And you see how that black dial moves? I want to set it on 20. When it gets to 20, I'm going to release it. It is now set. Okay? So now I want to set the PEEP, positive end expiratory pressure. I think a little lesson on surfactant will help us understand, first of all, what PEEP is. In a term baby, term babies have surfactant, or oil, which keeps the lungs, the alveoli, from sticking. So when a term baby inhales, their lungs expand. When they exhale, they come together. And they don't stick because there is surfactant or oil there. A preterm baby, particularly an extremely low birth weight baby who doesn't have a lot of surfactant, if any, it's really hard to open those lungs. And then when they exhale, they stick. So when they try to inhale again, it's really hard to open. So somebody got the idea and said, well, if you have an extremely low birth weight baby, what if after the baby inhales that we never let the lungs totally close or touch? We keep a little bit of pressure there at all times. So when the baby goes to breathe again, they don't have to unstick themselves. They can breathe and expand their lungs easier. That is what PEEP is. PEEP is that pressure in the lungs left after the baby exhales. All right, so how do you set PEEP? Put your oxygen back on. Very similar. You occlude the bottom just like you did when you set the PEEP, except you don't occlude the top because your PEEP knob is on the top. So let's turn it, and we're going to watch this black needle go to 5. When it gets to 5, it is set. Okay. So that's all well and good. So how does this work? Well, once this is set, you will see the NICU put the mask on the baby, and they will breathe just like a regular baby, just like a regular bag and mask. Ready? Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. And you can see the chest going up. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Okay. And that concludes your neopuff. So 2 values that you need to set in the OR hallway and outside of Rose's office. And generally I ask if they have any questions. And basically, you know, the focus of this station is setting the PIP and the PEEP. Okay. This next station is the UVC placement. Some of the things you want to start with is by saying this is a clean, not sterile procedure. It is also a temporary procedure. The first thing we want to do is get our, materials together for the UV line. So you need your UV line. The NICU likes to use a pigtail, which allows an extra port and flexibility, a 3-way stopcock, and a 10 cc saline flush. That's the first part. The second set of materials that you need has to do with the cord. You need a tie, a cord clamp remover, a blade, a popsicle stick, suture, and Tegaderm. So let's come over here and make pretend we are opening a UV line. We only want to open the top a little bit. First thing we're going to do is we're going to put our pigtail on. Okay. Then we're going to attach our 3-way stopcock. Then we're going to hook up. Let me just get rid of the extra air here. Our flush. And then we're going to give it a little flush till we see water coming out the other end. And there we go. Okay. So that UV line is now prepped. So now what we're going to do is we're going to take a tie, and we are going to tie it at the base of the cord. Okay. And the trick is here, you don't want to tie it too tight or the UV line can't get in. However, you don't want to make it too loose or else blood's going to squirt out. All right, so here we go. We've made a nice little tie. Now we're going to remove the clamp. Okay. Then we're going to take popsicle stick, actually. There's a popsicle stick here, and I'm making pretend. We're going to use a blade, and we're actually going to cut a piece of the cord off here. So this will give us a piece of fresh cord that's not clotted on the end. Once the new piece of cord is exposed, we're going to hand the doctor the UV line. And he is actually going to place it right here in the large one. Remember, Ava, 2 arteries, and the big one is the vein, right here. Let me see if I can. I'm making pretend I have gloves on. So it would go right in here, in the vein. And he would insert it about 2 to 4 centimeters or until he saw blood return. Once he sees the blood return, we're going to give a little bit of a flush here. So I have been told that sometimes they will suture this down and then they're going to put a tegaderm on top of it, and they will transfer the baby to the NICU like this. Once they get to the NICU, they'll take out this UV line, put a new one in under sterile conditions. And that is the end of the UV placement. I find that when I do this station, if I set up my materials first, I flow easier. It tends to be an exuberant amount of extra stuff, and I tend to push that up to the top and only keep here what I need, and I put it in the order with which I need it. Okay? This next station is the thoracentesis or the pneumothorax release. Okay. In this station, I generally start with defining what a pneumothorax is, which is basically air trapped in the pleural space, generally from overinflation when we're bagging the baby, and as a result, the lungs cannot expand properly. So what is the pleural space? It's the space between the lung and the chest wall. What are some of the causes? There's generally 3. The first one we touched upon, and that's overinflation. In our haste to bag a baby who's not breathing properly, sometimes we give more pressure and an alveoli burst. The second cause is meconium. And we all know that meconium can plug up the alveoli and cause problems with air and gas exchange. And finally, preterms. We just learned that preterm babies have minimal or none of the surfactant that they need, so their lungs are sticky, and we can tend to, again, give too much pressure while we're trying to unstick the lungs. What are some of the signs and symptoms, or the clinical signs, of a baby who has a pneumothorax? Well, first of all, there's an asymmetry of the chest, particularly where the pneumothorax is. Their O2 sat is poor, and then their compensatory skills kick in. So they start to grunt, flare, and contract. Grunt, flare, and retract as they try to use their nares to pull in as much oxygen as they can. They also tend to get tachypnic, breathe really fast. But sometimes, even with those compensatory skills, They don't get enough air and they're still a little cyanotic. So the treatment is to release the pneumo, release that extra air so the lung can expand again. One point I like to emphasize is sometimes as the O2 sats are going down with a baby with a pneumo, sometimes people will give PPV. You want to stop that because when you give PPV, you are adding more oxygen into the pleural space because we have a leak in the alveoli. So release the pneumothorax and then begin the PPV. My next step is I go over my materials. And again, I like to have my materials set out before I begin. And I push away all the extra stuff that happens to be here because it just confuses me. You need an alcohol wipe, you need a butterfly or a dart, as the NICU calls it, a 3-way stopcock, and a 10cc syringe. No, it's a 20cc syringe. 20. So what you want to do is you want to open your alcohol. You want to hook up your 3-way stopcock to your butterfly, and then your 20cc syringe. Okay. Then what you want to do is you want to find your landmarks on the baby. The first 2 landmarks are the second intercostal space, mid-clavicular line, and generally that's right above the nipple. The second landmark is the fourth intercostal space, mid-axillary line. If you're going to relieve the pneumo via the mid-axillary line, you must turn the baby to the side that has the pneumo because air rises and the doctors can get at it easier. Okay. For our purposes, we're going to use second intercostal space, mid-axillary line. So you want to start the clavicle and try and find the 2 spaces. I tend to find my spaces easier as I get closer to the sternum. So this is my second intercostal space. So then you give alcohol to the doctor, they alcohol it off, and then the doctor will put in the dart perpendicularly, and then what you want to do is you want to withdraw. And you want to keep withdrawing as long as you are able. When you reach 20 and you fill the syringe, you're going to turn the stopcock off to the baby and release the air through the second port, keeping a running total of how much air is coming out. You're going to open it up again, continue to take air out until you can't pull anymore. And then you notice how many cc's. That's 15 plus the 20. It's 35 cc's you just evacuated. So now we're going to release that. Pull this. Oh, this is the one you go up like this. Okay. Trying to do 2 things at once. Here we go. And you're going to hold some pressure. I do see a tegaderm here on this table. I'm assuming that perhaps they put a tegaderm on. Having never actually seen one of these, that is my assumption. Okay. A couple of fun facts. For a term baby, you can get anywhere from 30 to 50 cc's of air out of the pleural space when relieving a pneumo. For preterm babies, up to 15 cc's usually. The final question I tend to get at this station, what's the difference between a pleural effusion and a pneumothorax? And a pleural effusion, I tell them, has an L in it, so that's fluid in the pleural space. A pneumothorax, as we know, is air trapped in the pleural space. And that concludes our station on pneumothorax. This also concludes our video. I hope you found it helpful, and as always, feel free to ask me any questions. Thank you very much. And thank you, Angela.
Hope you enjoyed the video.